thì mình sẽ sang tiếng Anh. Thì phiên tiếng Anh của mình năm nay rất vui là có tới 7 bài báo cáo, trong khi phiên tiếng Việt chỉ có 6 bài báo cáo. Thì ra thấy vậy. So may we begin the session of English presentation. And for the first presentation, may I invite Dr. Nguyễn Thế Huy from E-Hospital to present the first case.
So good afternoon, hi everyone. My name is Dr. Nguyễn Thế Huy. I'm from Cardiovascular Center in E-Hospital. And it's a great pleasure for me to be here in HT Hour. And today, I would like to present a challenging case of right coronary artery intervention in a patient with a heavy calcified lesion and how to manage to overcome the difficult during the procedure. This is our patient, a 78-year-old male with a medical history of hypertension and type 2 diabetes. And he was admitted in our hospital due to persistent chest pain on the left side. Unrevealed by medication. 2 weeks earlier, he had an unsuccessful attempt at RCA intervention at another hospital. On ECG, you can see the slight ST depression in the inferior posterior lead, and turbulence was not elevated. On echo, so hypokinesis of the inferior wall with a left ventricular ejection fraction, approximately 47%. And this is a coronary angiography. And I will give you a few seconds to observe the angiographic image of both left and right coronary system. You can see the patient have diffuse stenosis disease and involved on 3 major coronary branches. So the first question, which one is the culprit lesions? I believe most of you would agree is the RCA. And we also identify the RCA is the culprit lesions and decide to proceed with the revascularization of this artery. So you know that the patient have a previous failed PCI with a right coronary artery. So we had a carefully planned this procedure carefully to achieve the success. The right coronary artery is dominant and severe calcification in the middle segments. And our strategy is rotational atherectomy followed by balloon preparation using a non-compliant or cutting balloon, and finally drug-eluting stent implantation. And we knew this would be a challenge, and India the procedure Phiên like a 3 novel. We name each part of this novel, and now let's begin with chapter 1. So this is chapter 1. Sudden rupture when the microcatheter betray. The first step to advance the rotor wire across the lesion to prepare for rotational atherectomy. We place a temporary pacemaker to prevent slow flow and bradycardia, and we employ a 7-French AL guiding catheter via right radial artery. A run-to and SY will advance with support from Caravel microcatheter. And you can see the run-to can cross the lesion easily, but Caravel micro could not cross the lesion, and we push and rotate, but the tip become too stuck. And when we withdraw the microcatheter, the Caravel tip fracture. So what should we do next? Several ideas come to our mind. The first, we insert a second wire, or we use to micro snare, or we use another device to retrieve the tip of caravel. And this is what we do. We advance a second Y, but the Y unable to deliver the distance segments. We use different microcatheter to put the fracture Y tip distally, but it's unsuccessful. And why we still considering our next step. Luckily, when we jump pull back, is primary Y, the fracture caravel tip will retrieve along with it. You can see in the image when we pull back the primary Y, and the tip retrieve. So everything had to start again. And this time we use a Concept Pro microcatheter to support Y manipulation. But the story was far from simple. We were unable to advance run-to-end nets across the lesion. We switched to SDR and SDA, but all failed. The coronary flow began to slow. The patient developed chest pain, shortness of breath, requiring vasopressor support with noradrenaline to maintain blood pressure. Everything was getting difficult. So what next? What should we do now? We design use a steeper Y and select the Gaia second. The Y successfully crossed the lesion, but it entered the foramen. We check angio, we check echo, no pericardial effusion. So the key question now was how could we navigate the Y into the true lumens? If that doesn't work, would we give up and accept failure? We don't get up, just like the name of chapter 2, lost in the slow flow. The quest for the true lumen. We reshape the Y tip and attempt re-navigation. And luckily, the Y into the true lumens, but could not cross the lesion to allow for rotor Y exchange. We decide pre-dilation with compliant 1.05 and 1.5 tens. And we can advancing the cross-separal, and we exchange the rotor Y and prepare for the rotational atherectomy. And this is, we use 1.5 mm with rotational speed ranging from 150,000 and 1 to 170,000, slowly and step by step. And you can show the burr were able to cross the lesion successfully, and the coronary flow improves. We pre-dilate with NC balloon 3.015. We deliver first stand, but first stand could not be across the lesions. We use another second Y, and we pre-dilate again with a non-compliant balloon 3.550. And two drug-eluting stand successfully deployed. We post-dilate with NC balloon 3.5 mm. And this is the results. You can see the first and the after procedure. Maybe a happy ending. And so we saw the good distal flow with TME3. There are no dissection, no perforation, and no side brain loss. Post-procedure echocardiography saw no pericardial effusions. The patient with a hemodynamic stable, and we transfer him to CCU for further monitoring. The chest pain subsided, and he discharged 2 days post-procedure with medical therapy. And this is a take-home message. Severe calcific lesion remain technical challenging. Microcatheter entrapment and fracture is rare, but require stepwise management. While reshaping and re-entry into the true lumen can be life-saving maneuver, rotational atherectomy is an effective strategy in resident calcific lesion. Strong support, appropriate device selection, and precedent are key to success. Thank you so much.
Thank you very much for a very interesting case. And after you cross the lesion and then you think about the eye version to see that what is the underneath reason that makes you a lot of difficulty before, or you just go ahead with the ballooning and then standing.
Yes, I know the IVERS or OCT is very important for the complex lesions to optimize the results. But we are sorry because some case we don't have IVERS for all case. So this case we are sorry because we don't use IVERS for this patient. Yeah.
And one more question that in order to for this question for the young interventionist, that when you lost the wire and then you lose the flow. So what is the factor that make you think about the stiffer wire in order to rewire the lesion again, instead of use the normal wire like run through or even the softer one like a wireless, instead of you use the Gaia second? Is it correct? So what is the reason that make you think that you had to upgrade the stiffer wire?
Yeah. It depends what wire you have in your cut lab. So when we fail with the NS, run to NS, we switch to XDR and XDA, but we fail. And in this case, we need to a stiffer wire. So when in our cut lab, we have just some wire like Gaia first and Gaia second. So we choose the Gaia second in this case.
Thank you for very difficult cases, and you done everything excellent. So I think the first thing about the microcatheter. So which microcatheter you choose after this case? After you have this case, which microcatheter you choose for heavy calcification like this, Caravelle or Corsapro, because it's different. So in your opinion, what do you think? And the second thing is that why after you cross the lesion with the steep wire, Gaia second, right? So after that you can cross the lesion with the Corsapro, right? So if you cannot cross the lesion with the Corsapro, so what you do next in this situation? Yeah.
Yes, and we think so that if you use the Caravelle tip, you know that the Caravelle tip is slide and maybe easy to fracture than the Corsapro. So in the case if you have the lesion with a heavy calcify, I think maybe the next time we don't use Caravelle, and maybe we try another microcatheter for heavy calcified lesions. And in this case, if you can cross the microcatheter like Corsapro, maybe direct the rotor wire, maybe.
Actually, in this situation, if we have the device, promising device like Turnpike Gold, that's a very strong microcatheter, then we can cross the lesion easier.
Yeah.
But we at the lab we had any weapons, so we use the one we have.
Yeah.
But I think if in the near future we have the Turnpike Gold, then we can use that in order to conquer this kind of lesion. It's faster and it's safer for the patient. And very happy that you even you don't have that kind of device, you still have finished the procedure very safe for the patient. Thank you very much.
Yeah, thank you so much. Because when we join this HT world, we learn a lot of you, a lot of master. Thank you so much. Yeah.
We move to the next presentation. May I invite Dr. Lê Văn Tuyến for the next presentation.
Yes, dear professor and teacher in the panelists, good afternoon all colleagues. My name is Tuyến from City International Hospital in Ho Chi Minh City. I'm truly honored standing here to further my knowledge and also learn lots of new things. The topic of my presentation today is a wide decision in a dilemma. Come from listening to the heart. This favorite quote, great quote from Albert Einstein. It perfectly describes a challenging situation that I have had. A true dilemma when moving forward is impossible and moving backwards equally unfeasible. My hospital in the west side of the city, and the clinical case I present today involves a 66-year-old male patient admitted to the hospital due to exceptional chest pain with CSS grade 2. His vital sign, physical examination, lab test, EKG, and also the echocardiography is unremarkable. But when we do the stress echo, it shows a positive result in 6/17 region, which is the anterior one, the anterolateral one, and the basal anteroceptor one. Following this, the patient underwent a CT scan with the result indicated the total occlusion at the mid-LAD with a lot of calcification on the CT scan. With this calcification, I think I may got some difficulty in treating this patient. His diagnosis is a chronic coronary syndrome with stable angina CSS2, hypertension, diabetes, type 2, dyslipidemia, and recent ischemic stroke. Because of his recent ischemic stroke, he was treated with duoplevin and rosuvastatin, ezetimibe, and also the vastatin, amlodipine for his hypertension, and dapagliflozin, metformin for his diabetes. After that, we do a coronary angiography, and it shows total occlusion at the end of the proximal of the LAD, and to the mid LAD at the trifurcation of the first diagonal and the first septal, as we can see in the second video. At the trifurcation, and we see some collateral from the RCA with the re-enter grade 3, but mostly from the epicardial. The syntax score is 15.5. So regarding the indication for myocardial revascularization, according to the guideline of ESC 2024 for CSS, in patient with EF above 35%, reverse is recommended, in addition to guideline-directed medical therapy for patients with functionally significant single or two vessel disease involve the proximal LAD to reduce the long-term cardiovascular mortality and the risk of spontaneous myocardial infarction with the recommendation 1B. So how about the choice of myocardial reverse modality? We got a CTO with lack error ischemic with low syntax score, just 15.5. So we can proceed PCI with the class 1 recommendation. So to accept the complexity of the CTO lesion, the JSTO score is 2 points with a blunt entry shape and also present calcification. And 2 points, it means the success rate is around 68%. But I think this may be much lower with the junior doctor like me, right? And with the progressive, it's 1 point, 97.5 technical success, sound more promising. The progressive complication is 0 point, it's low risk. So we could do a PCI, but what is the strategy? According to the global CTO crossing algorithm, I got a CTOK with good distal vessel quality. We have some collateral but mostly from the epicardial. So I will do the antegrade first. Our strategy, we do the antegrade with the slender seat from the right radial, 7 Fran. We choose the guiding is EBU 3.5, 7 Fran. The microcatheter is the Cosebro SS. And my strategy is stepwise escalation from the filter ST, it cannot pass, and change to the Gaia first. It didn't work, and I had to use the Gaia second. After several times, the Gaia second crossed the lesion, then moving forward smoothly. Everything at this time going well, but suddenly the Gaia cannot go any further, and even put the guiding back out, as we can see in the second video. It's put my guiding out. I cannot go expand my gateway anymore. Something wrong, right? And insulating the guidewire may go into the volume, and that's the reason I cannot advance the guidewire. So I check in multiple view. It's the IO views, and this is the LAO view, and we see still the guidewire in 2 lumen. So at this time, I really don't know what's going on. I cannot advance the guidewire, and even cannot retract it. It already stuck there. And at this time, yeah, like Albert Einstein said, a wise decision in a dilemma comes from listening to the heart. I cannot do anything, so I slow down and I look more carefully to the heart. I use stand boot and I see clear to the more carefully, and I see hear what I saw. Here is this continuation of the guidewire and maybe the cause of the guidewire entrapment. So. Dr. Manoj Prilakit already gave us some factors that lead to this type of complication, guidewire entrapment or fracture, like guidewire channel deformation or body wire with a filter. But in my instance, I think the likely cause is guidewire over rotation. Excessive rotation of the guidewire leads to damage the guidewire and then lead to guidewire entrapment. So. Dr. Manoj also provides us algorithm to deal with guidewire entrapment. So when guidewire entrapment, the first important thing is do not pull hard. If you don't want the guidewire completely broke. To be honest, at the time I have tried to pull it back. It doesn't work, and it even makes the guidance go deeply into the LAD. So I had to stop. What is the second option? We advance the balloon or the microcatheter as far distally as possible and pull it gently. Yes, I do it. I use with the Cosap Pro, it cannot cross the lesion. And in the second video, I use a small balloon with a 1.0 balloon, but failed to cross the lesion. So I cannot cross the lesion, cannot use the balloon, cannot use the microcatheter. Here's my last option, advance a second guidewire next to the first one, and then inflate the balloon. Then burn the wire gently. Yeah, I try. I go with another second guidewire. Luckily, it across the lesion. I can change to the workhorse guidewire with either side and blue. And with the support from the guided blood, mother and child catheter, I can pass the balloon through the lesion and can balloon in the proximal cap to break it. After break the proximal cap, I can retrieve the guidewire. As you can see, the guidewire have a discontinuation with a little bit of unraveling of the coil of the guidewire. That's the cause of guidewire entrapment. And then I can proceed the PCI with one stand from the mid LAD from the proximal LAD to the mid LAD, and this is the final result. For summarize, here are some prevention from Dr. Manoj for us. For prevent guidewire entrapment, avoid channeling as much as possible. Avoid aggressive guidewire manipulation. Don't do like me. Number third, straighten tip before removing through a stand. How to prevent guidewire fracture? Do not pull hard, and no atherectomy over a king wire. Thank you so much.
I'm Dr. Nghĩa. I would like to see the EKG before you decide to intervention, because I know you use DABT before you do angiogram in this patient.
Yes.
I don't know but the patient had the OMI or not.
Yeah. Yeah.
It's very important. If not OMI, maybe see because the history of illness, the patient had only the little bit the chest pain before 1 or 2 weeks only. I think it's very new recently. I'm not sure it's the CTO or not.
Yes. Thank you for your question. Actually, he has experienced the pain for a couple of months ago with the CCS2 chest pain, and the EKG quite normal, no QA, silent rhythm, no QA, yes, and because of his recent ischemia a few weeks ago, that's the reason why he's treated with dual plebin. Yeah.
You plan to do you have you collect the data, the medical document of the patient. You predicted the patient after you do angiogram. You make sure you do the angioplasty and stenting.
Yeah.
Yes, if you would like to do the stenting, you must load in with the DAPT before you yes. I would like to ask you a question. The patient had, when I see the patient, I say coronary angiogram in the patient, I see when you do the angiogram, I saw the flow from the left main, proximal LAD, mid LAD, distal LAD. So it is the CTO or not, because I saw the anterograde flow from the proximal to the distal. You understand?
Yes.
Yeah,
thank you. Yeah, for my.
I saw a little bit. It may be the 95%. The subtotal occlusion only. Yes.
So I just want to have a big congratulations to Dr. Tuyến, because he encountered with very complicated case. 66-year-old male patient have the CTO LAD and entrapment and subsequently the fracture of Y. So I think it is very highly educational presentation, because he gave it a lot of G CTO and progression CTO and demonstrate how do you face with the very complication on the daily life. I have the two questions for you. The first of all, that what do you think? What is the primary mechanisms of the Y fracture on your case? And the second question, that why did you choose the balloon, the body wire, and the small balloon to retrieve the fracture Y instead of use another retrieval devices like the snare? Because I saw that you use the Corsair Pro and 1.0 mm balloon cannot cross the lesions. So could you answer to my two questions, please?
Yeah, thank you for your interesting question. For the first question, the mechanism of the fracture guideway. My hospital now using the old generation of the Ngày family, not the Ngày NS, and this made the main reason for unraveling of the coil around the guideway. And when we assess the rotation of the guide, I just one side. Yeah, just one side. I do not rotate it back, and I just rotate one side for 2 months, and that's the reason why make the coils of the guideway unravels and make the guide discontinuation, leads to damage the guide, leads to guideway entrapment. Yeah, that might be the mechanism. With the newer generation of the Gaia family, like the next Gaia, maybe we can limit this type of complication. I think so. For the second question, why I have to use the second guide instead of the other device, because I cannot cross the lesion. I cannot cross the lesion. Like Dr. Manot private the algorithm. For the first step, we should try with the microcatheter or the small balloon. If we can cross the lesion, we can break the proximal cap and we can retrieve the fracture guideway. But I cannot do it with the Corsair Pro. I cannot do it with small balloon. So I had to use another guideway for B-side, go B-side, the first one, and then use balloon to break the proximal cap so that I can retrieve the fracture guideway. Yeah, that's the reason why.
I think the primary mechanism, because you go into the fold lumens, and sometimes you go into the calcify microchannels. So your title is very important. Listen to your heart. So if you feel any resistance, don't push the wire. So you always go very gently, because sometimes you go to the fold lumen and it folds back on itself and make the knot. So that's why your wire fracture if you push forward. So I think that is a primary mechanisms. Once again, a big congratulations.
Yes, can I
Thank
had
you.
some comment for the speaker. based on what you presented to us, and I see that we can say that this is a functional CTO also okay for you, but the functional or real CTO is very tough for the operator. But they try to explain the first question of Professor Dak, that what is the reason behind that? That's the main important, because when you cross the lesion already, quite easy, is it?
Yeah.
Correct? So, but after crossing the lesion around more than 20 millimeters, and then you continue pushing and getting bouncing back. That's the reason I'm thinking about that your wire at this moment, you have to de-escalate the wire. If you go to the true lumen and then the distal wire keep poking the vessel wall after the lesion. So if you continue pushing that, so it go be outside the vessel. And I think that is the point of time that I think you should de-escalate. For example, you use the balloon in order to do the ballooning for the lesion and then down through the softer wire. It's easier. Otherwise, you keep rotate the wire and then you make the wire stuck inside and firmly inside the lesion, and then maybe it's broken the wire also. That's my thinking about the lesion. Thank you.
Only one comment about the wiring for the heavy calcification CTO. So in some experienced doctor, when they do the CTO, especially for the heavy calcification and long CTO, they would do maybe the first step is stiffer wire, and after that, when we cross the proximal cap, maybe we extend to the softer to go for more distance, so it's safer for the CTO, especially for the calcification. So in this situation, you don't do that. So can you share with us your experience about the strategy to do for the calcification? Because this patient will have the CT scan before the procedure. I think it's a good point. So.
Yeah, thank you for your question. From the beginning, when I crossed the lesion with the Gaia second and the Gaia Y can go smoothly, I think that I can finish it quickly. And I try to cross the lesion and as far as possible to exchange to the workhorse Gaia Y after advance Cosai Pro, yeah, something like that. And when I try to put the Gaia Y, but the Gaia Y, I cannot advance it or even cannot retract it. And I get your point. At that time, I should do slower, and when feel resistant, I can change to another Gaia Y, maybe decrease to the softer Y to prevent damage the Gaia Y. Thank you.
Thank you, Dr. Tuyết. And may we move to the next presentation from Dr. Yim, Heart Institute of Ho Chi Minh City.
Good afternoon, Mr. Chairman, panelists, and everyone. I'm Dr. Nguyễn Bích Diễm, come from Heart Institute of Ho Chi Minh City. I'm very pleasure to have a chance to stand here and present my case about the unexpected complication occur right before we ending the procedure. This is my presentation. We have a male patient at 63 years old. He has a risk factor of hypertension, diabetes, dyslipidemia, and smoker. He has a history of prior MI and free vessel disease that PCI 1DS in LAD, and still have 90% stenosis in RCA and CTO lesion in proximal circumflex that 3 months ago. And he have heart failure with the EF about 27% and the CKD stay number 3. He was treatment with diabetes, with clopidogrel, statin, ezetimibe, and heart failure treatment. He come from the hospital with the worsening chest pain before 2 days before the admission, and hemodynamic was stable and examination was normal. The ECG showed that it was ST depression in many leads, and the echocardiography showed apical hypokinesia and with LVEF about 27% and moderate MR with no PE. The lab investigation have troponin was normal. And the CAG showed that the three vessel disease, you can see that the stent in LD is still in good condition, and the CTO lesion in proximal circumflex, and 90% stenosis in mid to distal RCA. And you can see that the RCA is a very tortuous vessel. And for this patient, we plan to PCI RCA and state PCI for the circumflex CTO lesion. We know the patient, the vessel of this patient have more angle, is very tortuous. We have to face with more and more angle even in the subclavian artery, and then the from proximal to distal RCA. And we all know that more angle means more difficult when we PCI. And for this, for the PCI procedure for this patient, we decided to have a radial access with a 6 French getting GR at the beginning, and we use Sion guide wire with microcatheter support, and we plan to put a stent for the middle RCA and DCB for distal RCA with the guide extension support. And this is the procedure for the patient. After more than 30 minutes, we could not go the wire to the distal vessel. After that, we change to the femoral access with guiding AR7 French and lesion preparation with balloon 2.5, and then we put DCB in distal RCA, and we put a stent 3.0 28 in middle RCA, and after that we bought dilate with a NC balloon 3.25, and this is the result. You think it's a good result, but it is not a happy ending. When we ending the procedure, we withdraw the system from the vessel. We realize that we cannot withdraw the guide wire. This is some causes that lead to guide wire entrapment that Dr. Tiếng mentioned before, and some prevention. And the causes that we may often face is we withdraw a knuckle guide wire when we ending the procedure. For our patient, we think it may be when we withdraw the system, we withdraw the AL guiding, we push the knuckle guide wire into the vessel, and then we pull it back, and it makes the knuckle tip of the guide wire stuck into the centroid, and then we cannot withdraw the guide wire. And when it occurs, we try to retrieve the guide wire into the system. First of all, we withdraw the guide wire without any support, and of course we fail. Now, as the Dr. Tiếng mentioned before, we have two options. First one, we can use a microcatheter to support when you withdraw the guide wire. We push the microcatheter as far as possible, then we pull the guide wire gently. Or we can use a small balloon to support when we withdraw, and then if failure, we can inflate the balloon to withdraw the guide wire. Because we have microcatheter available in our procedure, so we choose the option 1. We use a microcatheter Couche Pro XS to support when we withdraw the guide wire. And we couldn't withdraw again. After that, we want to have more support, then we use a guide extension and microcatheter support to withdraw. But again, we did not succeed. And finally, when we use a guide extension and a small balloon about 1.06 ml to support when we withdraw it, we can withdraw the guide wire into the system. But when we check the angle again, we can see the result. It may be when we withdraw the guide wire, the guide extension push the effort in the stand, it made the stand deformation. And you can see the result, the final result in RCA is still a 90% residual stenosis in mid RCA, and the TIMI flow about 2. And we realized that, and we try to rewire through the deformed stand in middle RCA to rely to both dilate it. But after about 1 hour of trying so many techniques, so many ways without a success, we accept this result and discontinue the procedure. And follow up for this patient, now the patient have no angina, the hemodynamic was stable, and the patient was transferred to the CCU for the monitoring. We treat the patient with aspirin, carbidoral, and heparin in 2 days, and after that we use triple therapy in 1 month, and then we use dual therapy until now. We follow the patient about 10 months. After 10 months, the patient have no chest pain, the symptom he had too, and have no MACE event, but the heart failure condition did not improve. The left EF was about 29%, and diameter of the left ventricular is 52 is increased to 65 mm. And we check the angle again to find out why. As you can see the result after 10 months PCI. The flow of the RCA now will better. The TIMI flow about 3, and still have 80% stenosis in middle RCA. And when the patient was stable, we check on the home procedure that we make for this patient and find out some problem that we do for this patient. The first one is we choose the unsuitable approach for the complex PCI. We choose radio access with 6-frame sheet with a guiding JR for the beginning. So we spend too much time and effort in the issue approach for this lesion. And the second, maybe have a stand malposition and we choose the wrong landing zone for this patient. We landing the stand in a very taut segment of the vessel, so it unintended create a draft for the guide wire. And the third one that is we use unsuitable technique when we remove AL guiding. When the guiding, we want a coaxial when we withdraw the guiding, and then we push the guide wire into the vessel. But right now we have a guide extension in the vessel, so that we don't need to push the guide wire. And when we push the guide wire to make the coaxial, we need to push far enough, especially when we have a stand in middle RCA. And last but not least is the technique when we withdraw the guide wire. First one, we we pull the guide wire so hard. When the guide wire tip stuck into the stent root, it may be not a J shape, may it have a W shape. I mean, when we push so hard, we will make the tip stuck more tightly in the vessel. And the second one is maybe it's better that we begin with a small balloon to support when we withdraw the guide wire, because the small balloon have a very soft tip and very flexible than a microcatheter. And when we choose a microcatheter, it may be better if we choose the small tip. The guiding microcatheter have a small tip. And in conclusion for my presentation, I have some message. In complex PCI, an appropriate access and supportive device, intravascular imaging guidance, along with the operator experience and composure, are the keys for ensuring the success and the safety for the patient. And complex and tortuous anatomy of the vessel may increase the risk for guide wire entrapment. And when we face with guide wire entrapment, a stepwise approach when using a small balloon or a microcatheter with a smaller tip to support may help we retrieve the guide wire safely. And the last one is every unwanted complication provide us an opportunity to improve the technique and improve the patient outcome in the future. Thank you.
Thank you very much for being brave to share the case. Actually, you are brave to share to the audience a lot of learning point for the young interventionist actually, because but I just give you you withdraw a lot of learning point already, but I give you another one. I think I have to give to you and for some young interventionist. Even for us also get some mistake when we do the intervention. When you already have the complication like this, so for me, I think you have to put another wire to the vessel first before solving this kind of complication. Otherwise you make it more trouble, because you make the stent collapsing, and then maybe the patient get no flow, and then the patient collapse. So in this situation, you can use the second wire with the same guiding. Even use the ping pong technique, also better for the patient. Otherwise, you make it like you close the vessel right away. So with the wire like this, so you make the whole system very strong. And then you use the balloon in order to make ballooning, or even you do anything you want, but the vessel still maintaining the flow. That's very important for you. But I think that's the most important learning point you to withdraw from this case. I didn't see any learning point when you withdraw the kind of this presentation. So I think the next case you have to put the wire in again, the second wire. And then you use the same wire, you use the ballooning in order to make it. And even you can withdraw, and you can use the closing wire in order to prevent the guiding sucking in order to cause some more dissection at the atrium of RCA. So that's the most important thing, I think, this case. But anyway, the patient still survived for more than 10 months. Very good, very lucky for the whole team. And I think with the next, I think we have to be more careful. Thank you.
Thank you.
Thank you for the excellent presentation. But I would like to ask you a question. Why is the causes of the wire entrapment in this patient? I don't know why, because on the presentation I don't see why.
Because the wire in a knuckle statement, and when we withdraw the AL guiding, we push the knuckle wire into the vessel, and then we withdraw, and when we withdraw, we make the tip stuck into the stent root. We think that.
why you don't think? I don't think. You go to the when you knuckle, you go to the substand.
Yeah.
Yeah, understand. After that, you re-entry the stand at the distal.
Yeah.
After that, you balloon up at the entrapment, the wire. I'm not sure. Yeah. So it is why it is very difficult for you to withdraw the wire when you balloon, micro, everything, guide tension with the balloon inside, everything. Yeah. I'm not sure. Yeah, maybe I'm not sure. So I ask you one question. You had IBUS or not? IBUS, the inside.
We
very
very
important.
regret. We very regret that we don't have IBUS in this patient, because one of the cause that we realize that maybe the stent is malleable, underside and malposition, that allow the tip of the guide wire may stuck into the stent root.
I think that this case is quite painful, but we learned a lot from the painful. I think that your case have some comment for you. First of all, I think that you should know your enemy first. I think in this case, the RCA is quite tortuous. So firstly, you should choose the femoral approach instead of the radial approach, and you choose a bigger catheter, 7 French, for more room for you to play with the devices. And I think that for this one, the pseudo lesions, so it's very important that you have to POT your proximal, optimal, the stent. You have the bigger balloon here, so very important. But you know that the soft tip of the wire, it is the weakness point of the wire, and when you pull back the wire, and the soft tip wire stuck in your stent strut, so that's why that you cannot pull back your wire. So. I think they're very comprehensive because you have to follow up the patient for the 10 months. So that's enough for you. You still see that the 90% the residual the stent, and the EF of the patient is very slightly improved. So I think that you should send the patient to the heart team discussion, and maybe we will send the patient to the surgery, to the KBIS, I think for a long-term patient. So I thank you. I think we learned a lot from the painful.
Yeah, thank you.
Yes, I have some comment about your case. The first thing, I think the intravascular imaging is mandatory for the complex PCI. So in this case, we have the wire trapping in the proximal stent because the stent is not well opposed to the proximal vessel wall. So we have some space, and the wire will be trapping during you put it back into the vessel. So if we optimize the stent, so maybe you don't have the situation like this. So the first one. The second thing is that when you have this situation, so I have some experience with another case that we can put the wire more, put it in more, not put it out, put it in more, and maybe it's work. It means that it's looping again into the stent lumen, and you can move it out. Not always put it out.
Yeah.
So sometimes we can push it in more and more. Yeah. Thank you.
Thank you.
Okay, thank you for your presentation.
Yeah, thank you.
And may we move on to the next presentation. May I invite Dr. Mai Sung An for his presentation, please.
Dear faculty, good afternoon everyone. I'm honored to be here to speak with you about the complication that happened on the coronary interventions. And as we all know, from the Dr. Andrew Goodis performed the first scale angioplasty, the science and technique have been developing continuously. And the science and technique commerce. And you know that following the success of Dr. Andre Guzis, there are many ongoing improvement in interventions. However, along with the successful, they have been on the many associated with the complications. And now I will give to, I invite you to join me on this case about to Andrea the complication and solution in managing complex recent interventions. Thanks for your presence here, and I hope I will receive many contributions from you, all of you. And my case study about the female patients, 70-year-olds, transferred from the hospital in middle of Vietnam. A chaplain complained about the chest pain 3 days ago. Had the ST elevation, inverted T wave from V1 to V6. Echography gave heart failure, reduced AF, with severe hypokinesis of the apex, antler, and preceptor areas, with a high of the high at geometry and anti-probability. And angiography show it is the stenosis in LD in proximal and about the 90%, and in the middle segment have the 70 to 80% stenosis. In this case, we have the bifurcation about the LD and the first diagonal. It's about the Medina 111 and the angle is 70 degrees. In the LCS, we have the stenosis in the middle segment about the 90%, and in RCA, you have a stenosis in about the proximal and little segment about 80%. And what should we do? I have a great rate score about the 196 and mortality risk is 30%, and CTAS score 1 is 30. And now, give me your answer. You choose intervention or you choose CABG. But I hope that you will choose intervention so that I can continue my topic. And so after I'm consulting with the vascular department, so the surgeon also agree with me about the plan PCI for this patient because the high risk in surgery. So I decided to plan the PCI for the patient after receive the family resent. And I think this is quite familiar with you, all of you. Yes. And what is your strategy? My strategy is at first professional stenting in LDs and gel balloon technique, and this be in LCS. And RCA can be invested in another time, but lies in not live rim. It's LED interventions with bow advance widen through into LD and first diagonal, and the preparation lesion by balloon filo 2.0. In the first, we yell balloon gives stand in proximal of LED with 2.5 30 and use a gel balloon technique to protect the diagonal with balloon fluido 2.0 and POT in proximal. And in the continue with stand in the middle of LED with stand 2.5 28 and use anti euphoria 2.75 in play from the 12 to 18 atmosphere from the middle to proximal of LED and final POT in proximal. So it is the LD intervention result. I think it seems okay and no complication. So it's so happy. But 3 days later, we have perform the scheduled intervention for the patient. In this case, have the 90% stenosis in middle segment of the LCS. We preparation listen by the balloon fluido 2.0. I think seems be okay after the listen preparation step. But unfortunately, the interventionist accidentally the losment the voice from the vessel lumen. And that's initially we assess the and about my charity DCB in the first we assess the lasso is not too large and maybe the have not have a calcified, so we submit BDCB for this patient. And now it is the result that when we pull out the balloon and the dissolvement the voice. And after we reattempt to the rewind, it's so difficult because it's wasn't through and the balloon now it's the reason that now balloon dilated is so difficult. It's not accessible. And the forceful of manipulation of the voice is called dissection. Dissection in the middle segments is about tip D to tip E of the circumflex. That's a patient now is the feel chest pain and increase of heart rate. The patient is so sensitive with the myocardium is kept here by the dissection of the circumflex. I think that it is the perhaps high rate of the extending of the dissection into proximal of the LCS. So we decided to plan stenting in the dissect side to uncover to the re-entry point. And after several attempts, we re-advanced the guide into the segment, into the vessel lumen, and stenting on it 2.25, 18. And after placement stent, I think the attending dissection in proximal has been reduced. But the patient reduced, and but the dissection is not perfectly resolved. And we continue with the smaller balloons, 1.5 to into advance the ditto segment and attempt to balloon dilated. After that, we have the set full that it has gone it's the contract standing in the yes. That is a contract intended in the vessel, and we burst it's maybe that's the guide and the bond is the sub-intermal in the segment. So initially we fell with Ivan the voice in by the lens roof. So we adjust the guide stiffer in order to penetration and stability. So we use the guide joint and navigating direction from the dissection to the ditto segment and use RCA Pro along with the joint PT. Okay, you can see in the second video we had the penetration, we had the perforation of the segment. It is a big called about of the wide joint PT because joint PT is deep for wide. Okay, because May is very happy that it is not too large, so we seal it by the RCA Pro, keeping at attending time in the vessel lumen, and use the wide joint inflation of the balloons. And after reaching the goal of the two lumen, we change the wide softer and withdraw the RCA Pro and continue with dilate the balloon vessel. And result is that the TME flow 3, some dissection tip AD in some position, but the patient will feel better, and the equipe will end the procedure of intervention in now. But have the misfortune really come to an end, and the 3 later, the patient had also angina, peeling inside echography, have the pericardial infusion, but no tamponade. What should we do? Equipe want to angiography now and maybe RCA intervention. And after RCA intervention, after that, before that, we assess the LAD and LC lesion, and equipe decided not further intervention in this LD and LC intervention, and only an RCA intervention, and the result of RCA intervention is okay. It's relatively favorable. But 3 hours later, a call from my colleague informing me that the patient has transferred into ICU. It's a hypotension, hepatitis shock. Maybe it's caused by the gastrointestinal bleeding. The patient, I think that he only used the anti-platelet medication by aspirin and clopidogrel rails. Maybe it's due to the chat from the patient, and maybe at the close time of its intervention procedure, Metlondin the anti-platelet medication. So it's called gastrointestinal bleeding. So the patient must transfuse for units red blood cell, and the PPI continue perfusions. The patient must stop the antiplatelet medication on the high of thrombocyte in the patient. In this time, it's the very role of the interventionist is very small. So I want to thank my colleagues because it's joining me on this battle to recover the patient life. And April so bring my flower after draining sky clearly. And the patient get out the ICU from 5 days of treatment, stop transfusion red blood cell. And the patient discharged from the hospital 1 week later in stable condition. And it is a re-examination result from next 3 months. Everything is okay. The heart failure is symptom is improved. Okay, and to inclusion my topic, I have some take-home message. Beside the patient with complete coronary artery disease, ongoing carries significant risk. And interventionists require to have a knowledge and experience to make accurate and sensible in the decision. In coronary interventions, keeping the goal within the vessel from the beginning to finishing is a crucial factor for the success. And Cocepro is a relatively reasonable choice for navigating through the septic lesion. And the roles of multidisciplinary collaboration in patient treatment is very important to have the best outcome. Thanks for your attention.
Thank you for your presentation. Since we are a lot behind schedule, we will move to the next presentation. May I invite Dr. Trung from Kiên for his presentation.
Good afternoon, Chairman and panelists. I am Dr. Chung from Kiên General Hospital. It is very privilege and honor to be here today to present my case. This topic is silent tear, the unexpected journey to the balloon rupture. My case is a 74 years old gentleman patient admitted to the hospital for the chest pain at the sternum and epigastric pain. He has no non-medical history, but he smoked 30 pack cigarettes per year. ECG showed complete right bundle brain block and tachycardia. Echocardiography revealed no regional wall motion abnormality, but he had a reserved left ventricular erection. He had a rising troponin. The diagnosis was non-active elevation at QMI. So the patient underwent emergency coronary angiography. The result is shown below. We had shock left main and a thigh lesion at the OM, and had the proximal LED CTO. In the right system, we have very tight lesion at from the mid to the distal RCA, and have the subtotal occlusion at BDA. And the patient has supplying the cholesterol to the LED. And the CT score is nearly 40, and this the main event the patient is lower for the cabbage, but when we discussed to the family member, the family member of the patient refused to the cabbage, so we decided to the deep PCI. And our plan is to use to did PCI in the RCA first. We use a GR 6-strand catheter. We run through blood wire. We use compliant balloon, and we intend to use 3DS stent. And we use the 2O balloon at the BDA to redilatation of the BDA and the RCA. And the procedure went smoothly when we deploy the stent from the BDA to the distal RCA with the real by 38 stent at 16 atmosphere. And the second stent we did from the distal to the mid RCA with the pre-5 by 38 stent at 18 atmosphere. But when we did deploy the stent, we observed the sudden pressure drop in the pressure in the pump, and then we saw the blood is entering to the pump. Then we suddenly think that it's the rupture of the balloon, and we take a pic. Then we take a picture after we deploy the second tent. We see the dissection from the mid LAD, mid RCA to the ostrom RCA, and the patient has chest pain. So what is the problem we have? It is the first time we see the rupture of the stent balloon. After the procedure, we withdraw the balloon. We see the rupture at the shoulder of the balloon, of the stent. This is the sign of the rupture. It is shoulder of the balloon. Why we start? When we deploy the stent with nominal inflation, sometimes the plug is very hard in the calcified and the central part of the balloon. It compressed in the shoulder. It may be opposed to higher pressure. If we did overpressure, like my case, we did an 18 atmosphere. It's the rated burst pressure. If we had an essential pressure, especially in the shoulder, the edges of the balloon, it can cause material to thin and rupture. It can lead in potentially to dissection and injure the vessel like dissection. In my case, the rupture can occur in the balloon shoulder because it's the transition zone between the part of the balloon contracted by the stent and the unrotatic edge. So it can rupture at the shoulder of the balloon. This is the mechanism of the balloon rupture. When we did a sexual balloon, over the pressure, it can lead into the rupture of the edge of the balloon. It can move. It can reach dissection retrograde to the proximal and can it can move along from to the sinus transverse, or sometimes it can go to the descending aorta. And after that, we did very quickly to third 10 is about the 3.5 by 38 stent at the mid RCA to the proximal RCA at the 16 atmosphere. And after that, we also see the contrast to retain at the root of aorta and the sinus of transverse. So we did the fourth stent. It's the 40 by 50 millimeter stent at the proximal RCA to the ostrom RCA. And after that, we see the result, but still it's the contrast standing in the aortic root. But the patient has decreased chest pain, so we stopped to the procedure. And after 1 week, we did a CT scan the aorta. We see the aorta in 3D. We don't see any dissection from the aorta again. This is one more view about the aorta. And we search any complication like we did in this case. So we found some aorta coronary dissection in the literature, but we don't have any case about the stent balloon rupture. We found some case about the aorta coronary dissection when we did a CTO, especially in the RCA procedure. Sometimes we see the catheter can cause the dissection to the aorta coronary dissection. After 1 month, the patient has to take angiogram again. We don't see any contrast retaining in the aortic root or or sign of Valsalva. So this is about the another view about the RCA. So we don't see any dissection. So in my conclusion, I think aortic coronary dissection was rare, but rupture balloon of stent were extremely rare. But we have this case is very unlucky. The coronary injury occur more common when we doing PCI in chronic total occlusion or RCA intervention, and it can extend it to aortic root. Aortic dissection were often fatal and had worse outcome than spontaneous dissection. Stenting were an option. Surgical may be required. We must learn to manage complication and follow up the patient. And the most important thing I learned from this case, never deploy the stent with the excessive pressure like rated bus pressure. This is my important lesson for me, and I think it's for you, the audience. Thank you very much.
Yeah, thank you. Thank you for excellent presentation. But there is not enough time for now. So I move to the next case with Dr. Nguyễn Đăng Khoa from the Nhân Gia Đình Hospital. The cath lab nightmare. Prepare to be unprepared. Yes. If you have any the audience had a question, any comment, you can see the directly to the presenter to discuss about that after this session. Yes. Thank you.
So hello everyone, hello the chairman and the panelists. Thanks for sharing me with me here today in this lovely afternoon at Nha Trang City. My name is Nguyễn Đăng Khoa. I'm from Nhân Gia Đình Hospital, and today is an honor for me to stand here and present our case. So you heard a lot of nightmare. So let's come to our my night shift nightmare, and hopefully you learn some lesson from it. So this is a 53 years old male patient admitted to a hospital with cardiac arrest, and he has a history of hypertension and smoking. And he had chest pain for nearly 2 hours and left arm weakness, and he went to the local hospital for MRI, brain MRI, and then he collapsed during the brain MRI. And after successful resuscitation, the patient was transferred to Nhân Gia Đình Hospital. And at our ER, you can see his vital sign is quite stable with noradrenaline, and he was intubated, and his brain MRI was normal. And on the EKG, you can see that the SD elevation on the V1 and AVR and SD depression in multiple leads. So at this moment, his diagnosis was the in-hospital cardiac arrest with successful resuscitation, SCI-C cardiogenic shock, and non-SD elevation, ACS R2. So we immediately activate our cath lab team. So on the CAG, his RCA is quite normal, so I don't show it. And on the left side, you can see that he had a significant lesion on the left main. And after the CAG, his hemodynamic was like unstable. We had to increase the dose of noradrenaline, and we have to place an IRBP. And our strategy was to stenting the left main LAD, and we used the 4.024 DES. And after the stent, everything quite good, and his hemodynamics quite stable. And do you satisfied with this result, or would you like to do something else? So in our case, you can see that the left main is quite big, and we want to optimize more of the results. So we use another NC balloon. We like to use 4.012, and we go up to 18 and 22, and we got better result. And at this moment, we could see we achieved the door-to balloon time just 15 minutes. And everyone in the cath lab team yeah, hooray, and we did a great job today. However, the smile didn't last long. Immediately after the NC balloon post-dilation, the patient cardiac arrest, and we had to do CPR, and everyone what the heck? And we do immediately the CAG, and you can see that no flow to the LED. Yeah. And in this moment, we thought that there may be some like no flow phenomenon. So we use a lot of adenosine, adrenaline, but still no flow, and patient like just like this. And then with desperate efforts, we use another stent to cover the distal side. We thought that there dissection of the distal of the stent, but still no flow to the LED. So at this moment, we call for the emergency echo, and wow, it's acute tamponade at his heart. And after remove of 500 milliliter of blood, we think that there might be free wall rupture. But on the ventriculogram, no rupture at all. So what causing the pericardial effusion? So we take a time out and we look back. This patient actually had left arm weakness before to admission, and he went to the local hospital for the brain MRI. And on the CAG, when we look back, we could see that there's contrast staining in the left valve of our sinus. And you could see that our diagnosis was cardiogenic shock. However, his left ventricular function like quite good, and even we could see his left ventricular after we do CAG. So we might think that he has severe aortic regurgitation, and all the clues turns out to be he has something with his aorta, and small mistake that lead to big impacts. And then we pull back our pigtail, and wow, he had rupture of aortic dissection. And the patient had bidirectional aortic dissection, which compromised the left main coronary artery, which caused him the AMI. And when we post dilation with high pressure, we rupture the junction of the aorta and the left main coronary artery disease, coronary artery. So we look back to the literature. We could see that the incidence of the AMI due to the aortic dissection is quite rare. It's just like 8.5 patients per 10,000 patients. And the mortality rate could go up to 95% with medical therapy. And up to now, there are no official guidelines for treat this kind of patient. So we look for some registry. You could see that in the small Japan registry, in the patient we treat with surgery without the PCI, the mortality rate could reduce to like 41%. And if we PCI the left main or the RCA with compromised by the dissection, and then we give a patient for a surgery, the mortality rate could just like 24.3%. So we learn a lot of painful lesson. And you can see that in the disease which are rare and lethal, anything could happen. And just like Murphy, the Murphy law, anything that can go wrong, will go wrong. And we don't expect this complication at all. This is our case. Thanks for listening. Thank you.
Thank you for very good presentation. Because we out of time, so we go to the next and also the last presentation before we have some question from all the audience and also the panelists here. Please welcome the next presentation from Dr. Trần Quốc Bảo.
Good afternoon, everyone, dear judges, professors, and on college. It's such my honor to be here today to share with you my story. So before I start my topic today, I would like to have you one question. Have you ever felt get lost? Not in the woods, but not in the maze, but in the heart, in the coronary vessel heart. So welcome to my story today. Into the unknown, I was led away through a blunt gap mystery. I'm Dr. Trần Quốc Bảo from Huế Southern Hospital. So my story begins with a 67 years old female patient admitted to the hospital because of the angina. And she was diagnosed with non-ST elevation myocardial infarction with high sensitivity thrombin. And she also got some medical histories like hypertension, type 2 diabetes, and then everything is all right for her about the stable condition, and then we check angiogram. As you can see, tight lesion at the middle L6 and also the proximal RCA, and then the CTO proximal. Now let's have a look. This is the coronary angiogram of the patient. The blunt cap CTO of LAD at the proximal of LAD. And also there was 80% to 90% stenosis of the middle LCX as well. And another view, we can also see that the blunt cap is also very clear. And also we can see in the right video also the problem with the proximal of RCA as well. Here we go. We have the challenge here, the challenge of anatomy, a 3 vessels disease with a blunt cap. So what is the best, and how can we do the best optimal revascularization strategy for the patient? We checked the syntax score first, and it was high, 3.5. And in that case, what should you do? Should we do the PCI of LAD, or should we do the PCI of RCA and L6 and ignore the LAD? Or should we do the completely PCI, or we call the surgeons for the CIBG? So let's jump into my story. After hard discussion and the patient's choice, we decided to do the LAD. Normally, we started with the soft polymer jacket guide wire, and it's failed, honestly. It's failed many times. We changed to the stiffer one. It's failed again. And then we used the microcatheter spot. And at that moment, we can see the guide A more stiffer, more penetration function. And the guide A second can go through the vessel. So at that time, we feel relief. We feel relaxed at that moment. Finally, we made it. Because all the cardiologists here, we might know that in terms of the CTO PCI, whenever the guide wire can go through the blunt cap, we are almost reached the success. So we made it finally. But look closely here. When we check the contrast, we didn't see anything in this flow. So where are we now? We were into the unknown, the topic that I mentioned. So did we get lost at that time? We don't know, honestly, at that time. After feeling relief, now we feel so stressed. Go back with the vessel anatomy. As you can see here, there is a very close proximity between the LAD and the great cardiac vein. So maybe in that case, in our case, the guide wire might went through the great cardiac vein. So, a few moments ago, we felt happy. But this moment, we know that we are at the risk of perforation, risk of pericardial effusion, and also the risk of pneumonia. So at that moment, what should we do? Should we keep going forward? Or should we call the surgeons? So surgeons, come and help us. Now, so we are young. So as young as we can try to do the best, we keep going. At that time, we have something new, IVUS. We kind of, confident at that time because we use another guide wire to the side branch. And as you can see, the side branch is quite stenosis at the proximal. And then we have to use the balloon to breathe the light for a while. And then we put the IVUS probe through the side branch. And this is the IVUS result you can see. And what IVUS show us, guide us. Here, this is the side branch. And this one is the blunt cap of LAD. It was well defined. It was fibrous or calcified. But more importantly, it is the clear path for us to go. So in that, the next time that we have experience, we used under the IVUS guidance and the support of microcatheter and the guide A second. As you can see on the right video, the guide wire here, it went through the vessel under the IVUS guidance, quite safety. And at the time, now we feel more relaxed. Because as you can see here, the vessel and the flow is more clear. Now the path is more cleared. So let's go and let's jump to the patient. And then we exchange the guide wire with the microcatheter, and we change to the run-through catheter to make the procedure more easily. And with the support of microcatheter and IVUS, we pre-dilate first with a very small balloon, 1.5 and 2.0, and then we check the IVUS again in order to optimize the CTO lesions and to measure the diameters of the stent as well. And this is the IVUS of LAD. As you can see, the lesions are quite long, and there is also a myocardial bridge in the middle of LAD. So when the IVUS go pull back to the ostium of the LAD, you can see it's so calcified and fibrosis as well. But in this case, there's interestingly, like we do the PCI of LCX first. We put a stent, a drug-eluting stent, 3.0 and 30 millimeter. And then we use NC balloon for the L6 first, and then we perform the LAD PCI with 2 stents. And under the IVUS guidance, you know that with IVUS we have everything. We use the stent, and also we use the NC post dilation in order to make everything easier and better for the patient. And this is the final result of the patient. The TME flow is better, and the stent quite well expansion and well apposition as well. And more importantly, the patient is safe. And this is the IVUS check for the result. It's quite good. So here come to my take-home message. Why crossing into the cardiac vein is rare, but real. When you're lost in the unknown, let IVUS light the way out. IVUS sees what angiography can't see, and sometimes that changed everything. Thank you so much for working with me today.
Hỏi điều nãy giờ hỏi lúc 4 người mỗi đứa trả lời một câu.
So we still have 50 minutes. So for each presenter, we will ask only one question. Okay.
Em hỏi câu.
I have the question to Dr. Bảo. At first, the first question is that how can you know the wide in the coronary vein? And I wonder why don't you do 2 times at the first time? Why don't you do we use IVUS to identify the blunt cap at the first time? And why don't you do the stenting to serve at the first time? Why? Thank you.
Yes, you can. Chắc mình truyền cái micro suốt này hồi còn hỏi tới 4 em lại, mọi người sẽ trả lời một câu.
Thank you so much for your 2 questions. You know, it was quite hard for me to answer 2 questions immediately right now because this is also the question that I intended that you might ask me. So at the beginning, that when we know that we are into the unknown dimension, we check the contrast and the flow. Didn't see, I mean, the distal flow, and we see the flow quite, you know, quite, how to say, quiet. I mean, didn't move up, just stable. And then maybe we get somehow that something here. But because if we look so closely to the video, the flow a little bit go back. So maybe we think that this is a vein. And that's why we check the anatomy. And maybe that's right. And I also searched for more information about the way, about the serious case that can go through the cardiac vein. It's quite very rare. Just some case reports. So maybe that's why I don't have too much information or too more information literally mentioning about that case. So this is the case, and I can think of that situation because of the close proximity between the LAD and also the great cardiac vein. And the second question is like, why didn't we use IVUS at the beginning? Because normally at the beginning, at first we also prepare something. We use the filter XT first and guide A first, and also guide A2, and also microcatheter. And we think that with these kind of tools, we can do it. But we went to the cardiac vein. So because we can also see the side branch is so restenosis at the osteum of the stenosis of the side branch. And then, as I mentioned, we have to pre-dilate first with the balloon in order to put the IVUS probe through the side branch. And then we have a chance to put the IVUS probe, and then we use IVUS to help us, to guide us to the right way. And the question that you also asked me, how do I know that I go the right way? Because with the IVUS guidance, we see the blunt cap, and at that time, we just pull back manually. And we try to rotate and manipulate the microcatheter and put the guideway under the IVUS guidance. Thank you.
I think I take the chance in order to remind you that because when we do the CTO, if we're not sure that the wire inside the vessel or outside the vessel, we never put any device go beyond the lesion. Because in this situation, if the wire go out the vessel, so you keep advancing the microcatheters to make the big hole. So you have to think twice before you put the ballooning or if any device like a microcatheter. In this situation, I don't see any contralateral injection in order to make sure that the wire is the right position before you advancing the other device like balloon or microcatheter. So I take this chance in order to remind the young interventionist that before you ballooning the lesion, especially the CTO lesion, you have to think twice. Because the wire can go outside the vessel, but the balloon make the vessel rupture, it can cause the trouble and the patient collapse right away. That's my reminder for you. Thank you.
Thank you so much for your comments.
So I have a question for Dr. Xuân Anh. Can you tell us more very details about the rewiring technique when you rewiring the surf? Because how can you minimize the extending dissection and perforation after you make a lot of damage to the surf?
Thank you for the question from the faculty. It's so happy because in the end that I have a question, because that's now I'm sharing the case that I'm going to learn in many information from faculty and everyone. And I answer my question. It does that we will I use run through it solve the voice in function manipulation, and it is that the code sessions. And but in the cert I don't know it is sub. Yes, and I think that it is in the angiography we see. I hope that is the rat of the waist in the circumference. And when we check the 2 and 3 the angle, we see the lines in the maybe in the through the right waist of the circumference. So it means in the first, I think maybe we can wrong in the distal segment. So but I sure that because it's push stand, we are very soft and not difficult to not stuck. Okay, I think that I hope that it's right in the waist and we push stand in that. Okay.
So your surf is quite tortuous, and if you always use your caudal view, you cannot go to the distal surf. So the tips here that you always go to the cranial view to see the distal surf. So this one that you go to run to wire and you go as far as you can on the cranial view. Yeah, because your surf is quite tortuous and a lot of side brand, and you put into the small side brand, and you think that it's a true lumen, and you ballooning and you make a lot of dissection here. So the tips here, that's go to cranial and go as far as you can.
I want to say that because the patient now is not stable, she feel chest pain. That's and it keeps the stand because it's a high risk of attending dissection in the proximal segment. So it keep want to kill the circumflex and because of this dental segment, I think it's so small. It's so small. So if it's served, I can kill it, or it's not kill it. It's not so important. That's
So I have a question for Dr. Hua, because this is a non-STEMI patient, right? And
Yes.
we have the cardiogenic shock. And so what do you think about the echocardiography before? Because STEMI we have to do it emergency, but non-STEMI, so what do you think about the echo for this situation? Is this should we do it or not?
Yeah, thank you for your question. And in my opinion, this is in this case we rush a little bit because the patient was unstable and he just like a resuscitation from cardiac arrest, and he has the ST elevation on the V1 and AVR. That's like the left main disease. So we rush for the cath lab and we bypass the echocardiography. And we should do it immediately when he admit to our ER, yeah, to stratify the mechanism of shock and find out maybe some other kinds of disease.
Yeah, okay, thank you. So the second thing is about the left man standing. So I don't know how long, how about this patient, you did it too long ago or just recently, because we have to check the IVUS OCT for the left man standing, because if we check IVUS, sometimes we see the collapsing because of the hematoma of the dissection from the aorta. So maybe we have another direction to go with the diagnosis of the patient. So what do you think?
Yes, IVR is a good idea and is recommended by a lot of guidelines. In this case, it's just a recent case. In this case, the patient was unstable, and we have to rush. We have to put the stent into left main, and after the patient was stable, after the post dilation, we repairing the IVUS for further optimization and further see more something the mechanism of the disease. However, just like I said before, immediately after the NC balloon, everything, the blood pressure
Would like
gone.
ask you a question that when your team do the emergency case, left main disease, I see the all left main disease, from the osseum to the bifurcation, you deploy the stent. Is the stent outside the osseum of left main or not? I'm not sure, because when you go balloon up with the high pressure, you see the complication, the nightmare happen. I don't know why. If you because if you have the stent outside the left main, maybe it prevent the disaster and the catastrophes in this case. I'm not sure.
Yes, thank you, Dr. Nghĩa.
And I had a question. I think we have time in order to ask one more question. I think very interesting case actually, because we have to rush for the like a daughter balloon and etc. But in this situation, when we think that we have to put the IBB in, so do you usually check the contraindication for the IBB? Because sometimes we already have the contraindication, so but we forget that. For example, peripheral artery disease, or we have to aortic regurgitation, or even we have some aortic dissection upside. So I think Dr. Vo already said that we have to do the echo in order to make sure that aortic root anything okay or not, or even we do the big tail in order to make sure that aorta is okay or not before we put the IBB in. Otherwise, this is one of the factor that make the patient more like in danger than the situation they have. Thank you.
Yeah. Thank you, Dr. Hùng.
And we have a last question for Dr. Chung.
The doctor. After why when the patient had the dissection, but that's the final when you had a complication, rupture of the balloon, I saw the contrast stand, the dye stand. Why you push one more stand from the middle to the ocean? Why? At that time, your team think the patient had the dissection of the artery or not. I'm not sure. I don't see the image.
When we deploy the second stand, the dissection is from the mid RCA to the ostro RCA, and we see the contrast retaining at the ostro RCA and the root of the aorta. So we plan to deploy free stand, but when we did the third stand, there's still a dissection from the proximal RCA to the ostrum. So we must deploy the fourth stand to correct the dissection.
Do you think that your team use the cover stand is better in this case or not? Cover stand. You know, cover stand you can carry the small, a very small. The RCA diameter about 4 millimeter. When I see the image, maybe 5 or 10. You see the contrast imaging outside the vessel, about 10. This is maybe the population already. Why do you think your team don't use the cover stand is better in this case?
Thank you for your comment. Because in my cath lab we have just the cover stand size real stand, real cover stand. I think it is not enough to to deploy to the correct dissection from the ostro.
So Dr. Chung, look at back of your case. I think that the ostium I say is quite abnormal because I think that is low takeoff. So when you choose the guiding corridor, sometimes you damage the ostium, the RCA also. And I don't know that the stand balloon rupture is coincident with your iatrogenic or coronary. And when your catheter make the dissection of the ostium, so if you have a chance to do again, so would you put the stand of the ostium first, and then you deal with the mid RCA?
Thank you. Thank you very much.
Answer my question?
Yeah.
Would you put the stand of the ostium first?
I think when we took an angiogram before, we see not disease in the ostrum of the RCA. It's just proximal to the mid and it's along to the BDA. So our plan is that deploy the stand from the BDA to the proximal of RCA. But it suddenly when we did deploy the second stand is at 18 atmosphere. The recommend atmosphere of the stand is 16 atmosphere, but we did 18.
Your team
Yeah.
plan to the full metal from RCA on the RCA.
So the story now, dissection extending to the orders. So you have to seal the orders lesion first. So if I were you, I will stand the ostium, the RCA first, to seal the lesion not extending too far to the orders. So if the patient is still able, I will have the it's a guideliner, go there to deploy the second or third stand of the mid RCA. So I think that you should secure your ostium of the RCA extending to the aorta first. Yeah.
So only one comment about the situation is that you have the aorta dissection at the ostium of RCA. So why didn't you check the CT scan after the procedure and follow up the patient after that? And this patient, you just check the CT scan for after 1 week. So there's any reason for that?
I said in the literature, when we have aorta coronary dissection, we often check the CT scan after 3 days and 1 week. So I followed the case report. So I decided to follow the patient after 1 week. We checked the CT scan, and we saw no dissection in the aortic root again.
Okay, so in daily practice, I would check the CT scan just right after the procedure, and after that I follow up the patient after 1 day, 2 day, 3 day, and we check again. If the dissection going up more and more, we have to do maybe open surgery. So it's stable. I think it gives us some information when we follow up the patient. Yeah.
Thank you very much.
Thank you, the panelists, and thank you all the presenters. I have the pleasure to announce the winner of this session after due discussion between all the panelists and chairman. And I am very pleased to announce that the winner of this session is Dr. Nguyễn Đăng Khoa from the Gia Định People Hospital. Congratulations for Dr. Khoa. Thank you for your participation, and now we move on for the opening ceremony.